Hello, thank you for joining us today, Dr. Kazi. Dr. Kazi, you were an author for Chapter 2, Designing for Medication Safety of the book published this year, Design for Health, Applications of Human Factors. I'm excited to ask you a few questions about the chapter and yourself. Why don't you start by telling us a little bit about your work and your research focuses?
Sure. Hi. Thanks for having me, Grace. I am a research scientist at the MedStar National Health for Human Factors in Healthcare in DC, and I'm also assistant professor at Georgetown University School of Medicine. So I conduct research on how complex environments influence the nature of cognitive work in healthcare. And very specifically, I focus on medication safety. So I look at medication safety across the entire cycle of medication. So that starts from prescribing, then it goes on to dispensing medication, administering, and then monitoring their effects. So I look at what are the different types of cognitive tasks that are involved during this entire cycle. How do providers use health information technology, other artifacts to try and accomplish all of these medication related tasks very safely? And right now, one of the things that I'm working on is looking at prospective memory tasks in medication administration. So in general, trying to look at what are these future medication related tasks that nurses on inpatient units have to do when they are administering medications. So what we have found in our interviews with nurses is that they have a lot of tasks that they're able to predict ahead of time. So I need to give my patient medications at between 8 to 10 a.m., or I need to remember to follow up with someone at a specific time. But there are also a lot of unanticipated tasks that arise during the workflow. So this may be something related to going and reminding the pharmacy that, hey, you need to send up this medication for this patient, or following up with other providers on the care plan for patients. So what we've been finding is that although the health information technology that we have at our system is doing a pretty good job of supporting these prospective memory tasks, a lot of times there are tasks that the nurses will note on their paper tools that will help them remember this. So over here, the problem that we're really trying to look at is how do we really design tools to help nurses accomplish these other and unanticipated tasks in a better manner, in which they can leverage their work environments better, they can leverage health information technology better.
I think that's great. Thank you. So for our next question, can you give us an overview of Chapter 2, Designing for Medication Safety?
Sure, yeah. So this chapter was work that I had done when I was at the Armstrong Institute for Patient Safety and Quality at the Johns Hopkins University School of Medicine. So in this chapter, we look at the system of medication reconciliation and trying to see how it was designed around the goals of patient safety and medication safety in general. And this problem has been around for a really long time. So medication reconciliation, as defined by the Joint Commission, refers to assembling the best possible medication history and using that history to complete other medication-related tasks for the patient. So what we did was try to break down what are the different tasks affiliated in this entire process of medication reconciliation. And if you try and look at it from a task analysis perspective, then you can say that first you need to gather what the home medications are for the patient. After that, you need to compare how do these home medications relate to the ones that I want to prescribe to the patient. And after you reconcile those two pieces of information or those two lists, then you need to see how you can use that information to perform current and future care for the patient. So there are a lot of problems with medication reconciliation that have been recognized for a while. And one of the problems is that how do you really measure that there has been good medication reconciliation that has happened in a setting. So a lot of times it may be just that, okay, I have this medication list, but how do I know if it is good quality or not? Um, some of our work, we found that sometimes providers just obtain some medication information, but they may not obtain the details associated with those medications. So that was not very high quality medication reconciliation that was happening. Another problem is that because medication information is so complex and you can get it from a lot of different sources, there is a problem of multi-source verification. So imagine you're going into the doctor's office and they ask you, okay, are you on any medications? And then you give them the list. So over here, you're relying on your memory to remember that, okay, I take XYZ medications, these are the doses, these are the frequencies. Sometimes the providers may tell you to also bring in your pill bottles. So that is a way to try and get like a little more objective information, because if you only rely on the patient's memory, sometimes, and depending on the conditions that the patient may have, it may not be very reliable. So that is just one way to try and reduce that. And then you can also get your medication list from the pharmacy, things like that. So how do you really know which source of the medication information is giving you the correct information? That is another challenge. And then with this comes a lot of stakeholders that are involved. So of course you have the patient who's giving the medication history, but then you also have your prescribers. So you have your physicians typically, you may have medical assistants, you may have nurses involved in taking the medication history. So there is just a lot of complexity in the process. And currently there are a lot of unknowns about who should really be doing what. There are different things practiced in different settings, but as in most of healthcare, there is not really a standardized way of doing medication reconciliation. So what we tried to do in our chapter was look at the previous literature and see if there were any takeaways that we could take from there on what are guidelines that we could give to people, that these are the things that you should keep in mind when doing medication reconciliation. So there is a lot of really rich literature outside of human factors right now in pharmacy, in patient safety, on the quality of medication reconciliation. And this literature talks about how to assemble the list of home medications. So that focuses a lot on what we in human factors think of as larger organizational factors. So who should be involved, what should they be doing, what are the roles and responsibilities, things like that. So there is a lot of literature outside of human factors on medication reconciliation, and you can find this literature a lot in pharmacy, in patient safety and quality. And the way we looked at it was, how can we use the previous literature to abstract design guidelines for medication reconciliation? And we divided it up into two sections. So the first one was more around assembling the home list of medications, and that we classified as these organizational level guidelines that we think of in human factors when we think of, for example, the SEEPS model. So what are the stakeholders involved? What are the roles and responsibilities of these different stakeholders throughout the process? Where should we bring them in? What information should we provide to them? And then the second set of recommendations that we had from the previous literature that we were able to abstract was, how do you design the interface to really support reconciling between the home medication list and with what the patient is doing in their current settings? So this has to do with what are specific design guidelines for the EHR, what are the types of alerts that you want to provide to the healthcare providers, what information should you give to them at what point, and how do you make them know that the information that they have entered makes sense, or how do you give them that system feedback? So that was those set of guidelines we've included in our chapter from previous literature. And then adding to that, We also conducted a study in which we tried to look at what was the current state of the system in respect to medication reconciliation, and at what point in the system were there potentials for failures that may have an adverse impact on patient safety and medication safety in general. So we started off with observations just to understand what was the workflow like. And what we realized is that even though we may tend to think of medication reconciliation just as this is just like one stage, right, in the whole medication cycle. But when we observed outpatient procedures and outpatient interactions, we found that the physicians kind of got information about medications at multiple points in their workflows. So it wasn't that, okay, now I'm going to take the patient history, now I'm going to move on to medications, this is what the plan is. There were lots of things mixed throughout, and that made it important that you provide that medication information to the physician or whoever the provider is at all of those points of care. So you cannot just give it at one point of time. It needs to be information that is available throughout. We also found that there were a lot of non-healthcare providers that were involved in taking the medication history or the home medication list. So this could be clinical assistants. So again, when you go in, sometimes you may have an intake nurse, or you may have someone else who will take your weight, blood pressure, things like that. So what we had observed was that there were challenges in how the home medication list was being assembled by people who did not have the requisite skill to really get this information. And that could have led to challenges downstream where you don't have the accurate medication list, and that may result in suboptimal treatment for the patient. So we conducted after that a simulation study with providers to see how they actually went about doing medication reconciliation in the EHR. And we found that they looked at different medications differently. So if you had prescription medications, they try to get information about those medications. But if it was non-prescription or over-the-counter, like multivitamins, things like that, they tended to miss the any errors associated with those other medications, for example. So that kind of cued us about what could be the gaps in having physicians or other providers perform certain aspects of the medication reconciliation workflow, and helped us think about how can we better organize the system so that you don't have all of the weight only on one provider.
So what is the most important takeaway from this chapter for designers, researchers, and others interested in this topic?
Yeah, so for me, I think the most important takeaway is just understanding how complex the entire system is. And because of that, I don't think that there is one single solution or one single fix to improving medication reconciliation. I think the solutions lie in different areas and require an appreciation of all of the complexity involved in the process. So what we have done in our chapter is we've taken a human systems integration perspective to designing guidelines or questions that any healthcare setting can essentially ask themselves as they're trying to improve the process. And this HSI perspective, it helps you try and think about what are the different buckets that you need to think about. For example, under staffing, who needs to be involved? What mix of healthcare and non-healthcare providers need to be involved? Which providers would be most cost effective, for example? So those are questions that you can have from the staffing perspective. But when you come to the actual staff, what are the knowledge, skills, and attitudes that you need from those staff in order to be performing medication reconciliation? So do they know how to take a medication history? Do they know how to use the different types of technologies to get to the information that they want? Do they know how to separate important from irrelevant information? So those are the types of questions that providers can ask themselves. And then when it comes to what is the training that you should be providing, again, the training that you would want to provide a nurse or a medical assistant may be different from the training that you provide to a healthcare provider or prescriber. So, for example, even for medical assistants, what are different interviewing techniques that you can use with patients to try and elicit a more reliable history? With nurses, how do you really check and see whether the information that the patient is telling you, if that is reliable, if that is correct? How do you really use all of these strategies? And then we have this big bucket of general human factors engineering. So this is just what we do in general, right? What are the different elements of the system? How do they interact with each other? So what are things about the task that you need to consider to have safe medication reconciliation? If you have a clinician who has a 15-minute outpatient visit, that clinician is not going to have time to do an entire medication history, right? So in that view, how do you design the system so that you are able to get a good enough history to be able to prescribe safely to that patient? How do you really design the EHR? What are the elements that you need to embed in the EHR? What is the information you need to embed in the EHR to be able to get to the information that the clinicians want to be able to perform medication reconciliation? And then the last is, what are the safety related strategies that you need to embed in the entire system of medication reconciliation to optimize patient safety and to optimize medication safety in general?
Thank you so much for your time, Dr. Kazi. We really appreciate it, and we look forward to sharing this on our social media.
Thanks, Chris.
Thank you.